The use of diagnostic imaging in medicine has increased tremendously since radiology became a medical subspecialty in the 1900s. Professor William Rankin discovered the X-ray when he placed his wife's hand on a photographic plate and exposed it to electromagnetic radiation for 15 minutes. In the early days, a typical head X-ray took up to 11 minutes of exposure time. Today, modern diagnostic images are made in milliseconds, and the radiation dose is as little as 2% of what it was back in those early days. With the advent of new imaging modalities like computed tomography, scans became better known as CT or CAT scans, and magnetic resonance imaging or MRI. There has been a virtual explosion of diagnostic imaging techniques in the past 25 years. Medical diagnostic imaging has come a long way in the last century, and so has its frequency of use. For example, there were 3 million CT scans in 1980. Currently, that number has reached 62 million annually. Diagnostic imaging now provides significantly more spatial resolution and contrast detail, and that allows physicians to make highly accurate diagnoses of smaller pathologies that could not even be seen with the older technologies. Welcome to another session of Voices in Health. I'm your host, Dr. Barbara Kostick. Today, we'll delve into the benefits and the challenges that diagnostic imaging provides. We'll have a close look of how we use diagnostic imaging technologies here at Washington Hospital to ensure the best possible outcomes while maximizing patient safety. My first guests are Dr. John Romano, Washington Hospital's Chief of Staff, and Dr. Bruce Nixon, Washington's Radiation Safety Officer and also a radiologist. Dr. Nixon, as we have seen diagnostic imaging improve, how has it changed since you started doing it?
The main difference is we have a lot of different modalities now. We have CAT scanning and ultrasound were just started. MRI was in its infancy, and now we have PET scanning, and we have much greater usage of all those modalities.
Well, Dr. Nixon, what about the radiation safety officer? What do you do?
Well, the hospital has appointed me radiation safety officer to ensure the safety of patients and workers that may be exposed to radiation during the course of diagnostic radiology.
What do you do now to ensure patient safety?
The equipment that we use is monitored every year, calibrated. We have our doses minimized so that the exposure is the least we can. We shield patients with lead shields, make sure they don't get any radiation in areas that they don't need to get radiation. And then we have a radiation safety committee which monitors very closely all the exposure to not only patients but also to the workers. This is a telemetry badge I'm wearing here, and all workers that could potentially be exposed to radiation have to wear this, and we record that every month, and it's highly regulated by the Food and Drug Administration.
Dr. Romano, do you worry about radiation exposure?
Yeah, I do consider that. When a patient comes into my office, I want to do a good history and physical so I have an idea what tests I may need to order afterwards. When I'm thinking about the tests, I'm thinking what's going to give me the so-called biggest bang for the buck. What I'm thinking about is what's best for the patient. If I need to get a test, I need to get the test.
And I think it makes a difference also, about their past history. Because lots of times patients go to many different doctors, and they might have just had a CT scan a week before and not realize that, that it could cause a lot of radiation exposure for no real reason.
Well, you're absolutely correct, and there's a big emphasis nowadays to try to define and determine which procedures the patient has had previously.
Well, what about other places where we get radiation?
Well, our natural background radiation is significant, and it is going up over time. So we get about 300 millirems a year just in general background, and about a quarter of that of the population is due to diagnostic radiology.
So we're not a significant part, it's just more the cumulative effect of all of it then. Is that right?
Right.
Right, and the ambient radiation that we receive is sunlight, there's radon in the earth, So these things are naturally occurring, and there's nothing we can do about those.
We can't walk around with the tinfoil all over our
Not yet,
heads.
anyway. That's right. Sunscreens are good.
But I hear people are even worried about things like dental x-rays now, that we're making sure that we shouldn't do routine things.
Well, historically, the film used to be held by either the dentist or their technician. And over years, those people would develop cancers in their fingers.
And don't radiologists in general have a higher risk of cancer than the rest of the doctor specialty?
They used to. Barbara, you're right. About 50 years ago, we started seeing a higher increase of cancer in radiologists. But those were based on very high exposures in the early days before that we had all the new equipment and safety precautions that we use now.
So we really made a difference in looking at radiation safety and trying to modify what protocols and techniques and when to do the studies.
Yeah, there's been big changes, very positive changes. The equipment now is digital, and it really minimizes the number of retakes and the amount of scatter radiation.
Yeah, and I find now that the equipment is so good that we have trouble understanding exactly what we're seeing.
Well, that's where the radiologist comes in to help you.
Good, thank you.
We appreciate your help.
When we come back, we'll delve into the key challenges that go along with diagnostic imaging. And we'll look at some of the ways Washington Hospital is working to meet these challenges.
Clean kitchen surfaces, utensils, and hands with soapy water. 1 in 6 Americans will get sick from food poisoning this year. Keep your family safer. Check your steps at foodsafety.gov.
Experts do not agree on the risks of cancer from radiation exposure during diagnostic imaging, but they do agree that steps should be taken to eliminate avoidable exposure to radiation. Fortunately, there are a number of ways to ensure that patients are not unnecessarily subjected to radiation exposure. My guests in this segment are radiologists, Dr. Bruce Nixon and Dr. Mimi Lin. Dr. Nixon, what are these measures that can be taken?
Well, there are several measures. The most important one is that when the patient arrives with a prescription for the doctor, we make sure that the test that they ordered is appropriate to the diagnosis that's written on the prescription. After we decide to do the procedure, then we make sure that our machines are properly calibrated, that the patient is shielded in areas that don't need to be exposed, and that we use the lowest dose we possibly can to get the diagnostic information.
Dr. Lin, is there anything that influences how you do the testing, the patient size or the sex or something?
In certain types of testing where we might, such as CT scans of the chest, we might shield a younger woman's breast just to prevent any unnecessary exposure to breast glands. If we're doing just a chest x-ray, we don't need to expose the lower half of their body.
Well, you know, when we're diagnosing a problem, are there other choices besides radiation to use, Dr. Lin?
There are certainly many different types of tests in radiology. That's one of the great things in the recent onset for diagnostic imaging itself. We have lots of different modalities now. Something as simple as plain x-rays from 50 years ago to things like CT scans, which are highly detailed and sensitive, but do have a cost of additional radiation. We have other tests like ultrasound, which uses no ionizing radiation, just sound waves. We do have MRI, which also has no ionizing radiation, and there are wide varieties of tests that we can use.
So let's talk about the different kinds. There's ultrasound, which is no radiation because it's sound waves bouncing off objects like a submarine underwater. Is that what it is?
True, but ultrasound works wonderfully for solid organs. So things like the liver and spleen. Not so great for things that are full of air, like your lungs or your bowel. And also, its field of view is limited. You can only see a small area. It doesn't see the entire abdomen at one time.
Any suggestions on when to use ultrasound, Dr. Nixon?
The common indications are abdominal pain, look for the gallbladder, or if the patient has a diagnosis of cancer, to assess this possible spread to other organs.
Cyst versus solid too, is that a good place for
Yes.
ultrasound also?
Right. Ultrasound's great for superficial organs, definitely.
So let's go to the next modality. Do you want to go CT or MRI? Which one do you want to hit?
CT, I guess, because CT probably is the most common.
Uh-huh.
It has great detail. It shows the body, whatever we're imaging, in a cross section, much like slicing a loaf of bread. Now we're looking at all the cells within the bread loaf rather than looking at the crust on the outside. So we see a lot of detail. We can make great diagnoses with it, but it does have more radiation exposure compared to just a regular X-ray or some of the other modalities. So it really depends on what we're looking for. It's great when we are following up cancers, sometimes for investigating cancers that may be there, finding sources of pain, such as kidney stones or even appendicitis.
That's right, the spiral CT to look for a stone. Is that a limited scan then when you order like a spiral CT to look for a kidney stone?
Well, all of our CTs are done with spiral technique now, and we always limit it to the area that needs to be investigated.
And then do you adjust how many CT slices you take based on what you're looking for too?
Again, it limits the body part that we're interested in. So if we're interested in the abdomen and pelvis, we'll limit to that area. We'll try not to include the chest. We won't include the legs, obviously. And the more distance we cover, the more radiation exposure there is. So as in all our imaging, we'll try to get down to just the area that we're interested in. But it's just a matter of, like Dr. Romano had said, your bang for your buck. You want to make sure that it's really in that part of the body that you're scanning that we're even looking as a cause of the pain.
Well, what do you think about MRI then as opposed to CT? What are the advantages or disadvantages comparing those two modalities?
Well, MRI uses magnetic waves, which has no ionizing radiation, so it's a big advantage. And it's very good for soft tissues. Again, it doesn't look into the lungs because, number one, the lungs are moving as you breathe, and the scan is a longer scan than a CAT scan.
MRI does take a lot longer. A CT scan, you could cover an entire chest in 30 seconds or less. An MRI of a liver, let's say, would take you 30, 35 minutes to do. There is a problem with motion because we are in scanning for 35 minutes. It's not like you can hold your breath for that long. So there are some difficulties with it, but again, it's a great differentiator of soft tissues. It's great for things that hold still, like your brain, your spine, your joints. Think of all the athletes we hear about getting MRIs of their knees and elbows.
I didn't understand, what are PET scans? We didn't get to that last.
PET scan is a type of nuclear medicine scan. A nuclear medicine scan is a little unique from all our other radiology scans in the sense that it can show function rather than anatomy. Many of our other imaging is great for anatomy, CT scans, ultrasounds, but they don't tell us much about how that organ works. Whereas in nuclear medicine, we can give material that it has to be processed by an organ and therefore shows function. So a PET scan is only used to evaluate for cancers. We're looking at metabolic activity of a cancer and where that cancer might be located.
Back to radiation safety, let's just talk about the patient that has had a chronic problem. How often do you follow up on those problems? And you can use specific examples if you want to.
Well, in most patients, they really have to present with a new finding, a new clinical finding that's serious enough in the doctor's eyes to warrant getting a CAT scan. We really try to limit the number of CAT scans that are done. Ultrasound, it's not as important.
Well, I know we, on a lot of things like mammograms or follow-up on cancer follow-ups, usually it's 6 months. Is there a reason that it's 6 months? That's a long time that patients have to wait sometimes. And
things don't change that quickly. Even though 6 months seems like a long time, for disease processes, 6 months may be the bare minimum where we can detect a difference. We want to give it enough time that if change is going to happen, that we can see it. If we do it too soon, we might have to follow it up again, and that would be another exposure.
Right. And then can you talk just a little bit about cumulative exposure?
Cumulative exposure is what they think is the greatest risk for development of cancer over time. With a cumulative exposure, there's enough mutations that can occur that the body can't repair them all.
And so that makes it really important for the patient to share what other scans they've had done or what other procedures, maybe in other places.
We do typically have histories of our patients that come to see us, so we can see their past radiation or things that they've been done in our department. But that doesn't account for other hospitals. If patients go to other hospitals to get examinations done, we don't have records of those. So it's always great for patients to know what happened to them and what they've had done.
And again, has the knowledge that you get, the computerized knowledge, has that changed how you disseminate information or how you look at things now at all in radiology?
One of the great things is we're in different departments, so we're in the hospital or we could be over at the outpatient imaging center, and I can call up Dr. Nixon on the other side and say, hey, can you look at this picture? And he doesn't have to walk across the street to come see it now. He can just pull it up on his monitor and we can discuss it right then and there.
Okay, and the other thing I've noticed that I wanted to bring up is what you can do with the computerized images too. You know, you have little magnifying glasses so you can magnify certain parts. You can rotate it around, can't you? And with this 3D CD that you can do.
So we can take some of these cross-sectional imaging modalities like MRI and CT. We can use the computer to model all that data information and create 3D models so that you can turn them, spin them, see them in different places. It's really fascinating.
Well, and that might help with patient safety, since you don't have to do another study to find it too.
That's right.
Well, thank you. This was really informative. We'll be back in a minute with Dr. Romano and Dr. Lin to discuss Washington Hospital's diagnostic imaging options, procedures, and philosophy.
Now, some action from the courts. Billie Jean King renewing her rivalry with arthritis. First set, furious volley, and right to the net for a winner. Beautiful forehand there. Arthritis, stunned. And here, match point. Billie Jean with the ace, taking it in straight sets. Afterwards, a jubilant Billie Jean King.
Tennis is a weapon for me with arthritis. There's nothing like it for me to hit a ball, run to the ball, anytime, any court. I'm ready. Let's go.
What's your weapon against arthritis? Find out at fightarthritispain.org.
Diagnostic imaging is an important tool used by a wide variety of departments within the hospital. And that requires a great deal of ongoing communication and coordination between disciplines. Dr. Lin, as we've seen, how does that happen?
Most of what we do, it requires a physician order, hopefully with a diagnosis that helps us decide if the test that's been ordered is a good test for that patient. And then we all, of course, have a record of the results that have occurred, and so we transmit those results to the ordering physicians. And those that are consultants will have access to those as well. That way, people understand that what tests were done, what information is gleaned from those tests, where to go next.
Well, I know in my office I can pull up any kind of imaging study on my computer and look at it and read your report at the same time. And so I'll have the patient come in when we talk about something and go over, you know, the particular modality that we ordered and what we found and what to do next.
Right, and I think having those images in front of a patient is really very helpful. It helps them understand what it is you're looking for or what you found. It makes it much more concrete.
What about you, Dr. Romano? What are you doing?
Well, I think you were pointing out the concept of the physician portal that we have here at the hospital. So in my office, I can connect through the physician portal, and through that portal I can see the entire medical record that we have.
Yeah.
So that allows me to have basically instant analysis.
But don't you think it's important for the patient to take some charge of their own medical data too?
Keeping a diary of your medicines, your x-rays, your surgeries, all those things. If you bring it to the doctor can better serve you.
And for us, even the electronic medical record is an institution phenomenon for us. But if patients go to outside institutions, we wouldn't have a record of that. So only the patient would know that information, and being able to share that is really key.
We're only as good as the information we have. If we're going to take best care of the patients, we need the greatest fund of knowledge, fund of information to provide them that care.
I personally, people need to keep their immunization records up to date, and now they've got to have a radiation exposure diary. Is that right?
I think you need a medical history exposure diary, as you were saying. So things like your medications, things like previous surgeries, things like what x-rays you've had done.
That's right.
Those are things that are important.
What about these patients who just come in? I have back pain, I need an MR or a CT.
Yeah. Well, we get that sometimes, but I think that's because they don't know.
Right.
They hear that an MRI is a way to diagnose something, so that's what they think they want. It's the same thing. Patient comes in and they say, I want this surgery. Well, the first thing I ask them is, let's step back. What is the problem that you have?
Right.
And then we'll decipher what the problem is. Then we'll determine what studies you need, what interventions you need, but what's the problem first?
One of the exciting things coming out now is this, quote, BERT scale.
Oh,
Have you heard about that one?
It's a unit of measure that helps to associate radiation dose with common everyday things, something like background radiation.
You know, when we as physicians talk about millisieverts and things like that, it means nothing to a layperson, and it shouldn't really.
Right.
But if you tell them this test is like getting 2 days of sunshine, well, then they can relate to it.
Right.
And that, again, goes back to the education piece.
Yeah, and again, making patients more knowledgeable about their risk and the benefits of each procedure.
Right.
Dr. Romano, what do you think is the ability of the radiologist in looking at these different images?
First of all, I want to commend my colleagues in radiology because they do a wonderful job. When a layperson hears that we're looking at an image, they may think of a photograph. So anybody's looking at a photograph can recognize what's there because it's what we see in the real world. Radiologists are looking at interpretations of this invisible energy that goes through the body and then gets put into an image, and then they interpret, well, this is disease, this is normal. It's a really incredible thing that they do to
Yeah,
help
and
us.
Dr. Lynn, as you said, you see like on a CT scan, you see one slice of bread, and you have to determine how the whole loaf looks.
Correct. Yeah. Being a radiologist, it takes a lot of training. There's 1 year of a clinical internship, and then we have 4 years of training. And then most of us do at least 1 or 2 year fellowship to be able to do to interpret all these images that we see.
Well, what does the future hold? What are we going to do?
Radiology, well, diagnostic imaging always has lots of new things coming in the future, much of which is advancement on what we currently have. Everything always towards getting the best detail for the lowest radiation dose, so there are new methods coming for that. There's always new modalities in the horizon, things that are coming, some of which may be more functional rather than just based on anatomy.
But the other thing that I see happening is the portability of some of the machines that the radiologists use. For example, in the wards now, the nurses can use an ultrasound to determine if the bladder is overfull and needs to be drained.
Oh, not only that, we're going to have a CT in the operating room.
That's right, a mobile CT.
A mobile CT,
Exactly.
so you don't have to move the patient at all. You can localize the lesion right there.
Exactly.
Yeah.
Exactly. It's all exciting.
It is.
It's all exciting.
Thank you very much for coming and sharing this with us today. Dr. John Romano, Dr. Mimi Lin.
Barb.
Clearly, diagnostic imaging is a very effective method for discovering and examining the details of a wide range of medical conditions. We've also learned that as a patient at Washington Hospital, you can rest assured that we have made a careful, informed assessment of the value and the risk, however minimal, of any diagnostic imaging we prescribe. For more information on diagnostic imaging, please visit the following websites: